thank you to West Kentucky for giving me this opportunity to come and speak to all of you and share our journey and our family journey and an insight into the lives of many families that you will meet along your journey that deal with chronic illness. Chronic illness is not a fun thing, and all of us at some point in our lives are going to be caregivers, either of your children or maybe even your parents. And so hopefully today, if you are going into the healthcare field, something that I say can help you along your path of taking care of and caring for patients. Thank you for the nice welcome, Karen. A little bit more about who I am. Everybody knows when you become a mom, you become your child's first name followed by a mom. So I'm Caleb's mom. And so when we chose an avenue on internet, it became calebsmom.com. So if you want to reach out to me, find out a little bit more about epilepsy specifically, which I will touch on some today, but if you would like more specific information about epilepsy, there's a tab about that at my website. There's ways to access my books that are available electronically as well. There's some videos of some interviews that we've done collectively as a family and me individually that are also located on there. If you have a family member who's dealing with another family member with chronic illness, it could be a good resource for them. My husband's name is Chad. He's from Marshall County. We've been married for 16 years. Our daughters are Peyton, 15, and Camille, 13. There are my books, and I'm an autism and epilepsy parent advocate. The ASD stands for Autism Spectrum Disorders. Basically what that means, if someone has a child with epilepsy and they need to find another family member to gain some information from or access to other resources, they contact me. And I do that for parents independently, and then also referred different families from Dr. Gregory Barnes, who is a pediatric epileptologist at Vanderbilt Children's Hospital, and also currently or recently became a parent advocate for Dr. Paul Moore, who is a pulmonologist at Vanderbilt Children's Hospital. Basically, they just refer patients to me, and I direct them into whatever resources they need, or sometimes they just need to cry to somebody, and so I just provide the listening ear. This is our boy. His name was Caleb Asher Baker. He was born November the 7th of 2001, and he was diagnosed first with PDD-NOS. That means pervasive development disorder not otherwise specified. Basically, it's under the huge umbrella of autism. He was diagnosed at 3. We knew some things were not just right at around age 2, but there was a long waiting period for diagnosis. At 4.5, he had his first seizure. It was a partial complex seizure. It lasted around 10 minutes. We took him to the hospital. He had another seizure 3 days later, and he was flown to Kosair Children's Hospital, where we received his care for the first 1.5 years. Then he was diagnosed with irretractable epilepsy at age 5. Irretractable meaning that his epilepsy did not respond to 2 or more anticonvulsants at top titration levels. And so typically when you have reached that level with epilepsy, you likely, the effectiveness of those 2 drugs, if they do not do what they're supposed to do, the likelihood of your seizures being controlled dissipates. And so there are many children, and we'll get into some statistics about this, that deal with irretractable epilepsy. At age 6, his care was moved to Vanderbilt Children's Hospital, and upon doing some additional testing, we were given this nice long name of Caleb's condition. It's called diffuse bilateral cortical dysplasia. Basically what that means is that in utero, his neurons did not attach to the cerebral cortex. So he had all the white matter that covers your brain were just avenues for his seizures to travel on because they were not connected correctly. At age 7, he developed chronic pulmonary aspiration as a result of esophageal relaxation, which just basically means the medications did some really bad stuff. And so it over-relaxed his esophagus to the point that anything that was put in his mouth directly was aspirated into his lungs. The next trickle-down effect were GI and mobility issues. He contracted C. diff. He had an ileus. And at age 9, multisystem disease was suspected. They never were able to pinpoint that. However, he was diagnosed with aplastic anemia, which means that his bone marrow quit making blood. It was possible that he had myelodysplastic syndrome. Many times that is seen in the geriatric population. It is also possible that he had a mitochondrial disease. He left this earth for heaven on January the 15th of 2011, and through taking care of Caleb, we came in contact with some really great people, great physicians, great nurses, great therapists, and in sharing how they cared for us and some of the greatest things about them, I can impart that knowledge to you all today. So our focus is going to be about young patients and how we can help them. And the first thing we want to focus on is knowing what you're going to be meeting. It's difficult to face children who are ill. Facing children who are chronically ill is really tough because they're innocent, they just want to play and feel good, and so many times they are facing things that we as adults can't even handle. They are debilitated, they face constant regression. So knowing what you're going to be meeting as a healthcare provider is really important. The incidence of autism in the United States has increased to 1 in 88 kids. That's a staggering number. And for whatever reasons research wants to pinpoint, or whatever theories exist out there on the reason for the increase, the fact remains that it's on the increase and likely will continue. So you're going to come into contact with some of these kiddos. The other portion that I want to focus on is kids with epilepsy. Epilepsy in the United States affects more than 300,000 children under the ages of 15. And more than 90,000 of those will have what we talked about, irretractable epilepsy, meaning that it's not going to respond to medications or not respond effectively to medications. Epilepsy is the third most common neurological disorder in the United States. That's after Alzheimer's disease and stroke, which typically affect the elderly population. Its presence is greater than cerebral palsy, Parkinson's disease, and multiple sclerosis combined. So despite how common that is and how that shows you indeed how great the number of people affected are, it's one of the least understood of chronic major illnesses. And even though 1 in 3 adults will know someone with epilepsy. The mortality in individuals with autism with and without epilepsy, this article was published April the 15th of 2011 in the Journal of Child Neurology. And basically what it said was that based on their tissue donations, children who have passed away that are known to have autism, this is an autism tissue program, upon evaluating those tissue samples from those children, 39% of the confirmed cases of autism also had a confirmed diagnosis of epilepsy. This study also concluded that when epilepsy and autism occurred together, that the mortality rate increased by more than 800%. So that is a staggering and terrible statistic, especially when you're talking about a pediatric population. The literature also indicates that there is a prevalence, and this is general, of all incurable diseases annually affecting 10 out of 10,000 young people. That's ages 0 to 19 years old, with an annual mortality rate of 1 in 10,000 of those young people from birth to age 17. So these are staggering statistics. What that means is you will treat pediatric patients who face chronic illness in the ER, in the hospital, in a clinic, in a therapy setting, home health, and eventually in a palliative care setting or a hospice setting. So we need really great people who can be compassionate and can take care of these kids. So what are the best ways to help young patients? Number one is getting past the code. Here's a bunch of them. Most nursing students know what these are pretty quick. So do parents. Parents' families have a Google MD. If you walk in and you start rattling off code, they're going to go look it up. They're going to find out what you're talking about. They want to know what's going on with their kids. So if we get past the codes, if we look past, if you say neutrophils, I'm going to ask you what their white blood cell and their red blood cell counts are. I'm going to ask you about teardrop cells. I'm going to ask you about myelodysplastic syndrome. So if you're going to drop the code, be prepared to answer the questions about it. It's really important. Parents know usually where they're going. Most of the time they have a feeling that this is not going right. They likely have done some research. They likely know what path they're traveling on. So it's really important to make sure that you're not just rattling off the numbers, that you're really connecting with them and telling them what those codes mean. Not all parents are going to know. Sometimes you're going to have to be the educator in the situation. You're going to have to step in there and give them a few more pointers, tell them what really is going on, identify what's going on, and let them learn, let them be educated. The next thing is talking to the patient. This is difficult when they're kids, because if you walk in with a white coat, they might have a meltdown. Some kids are just terrified of going to the doctor. You may have kids of your own that you walk into the doctor's office and they melt into the floor. So when you're talking about chronically ill children who have hospitals as their home a great deal of the time, they know what they're walking through with a lab coat on for. They understand that. So talking to them and creating a relationship with them from the get-go is really important. So in doing that, you also need to be realistic that they likely are not going to talk to you. Some of these children are nonverbal entirely. So how do you best communicate? And that requires you talking with the family. When you meet a patient, if they say they're nonverbal, ask the family, which is the best way to interact with your child? Do they need picture cards? Is it better if I sing to them while I'm interacting with them? There are a lot of tricks that are out there. And so if you'll just ask the family what the best way is, likely they're going to tell you. And also, it lets the family know that you really care about their loved one and that you're trying to connect to them and that you're really putting the patient first. Next is training caregivers. Some caregivers don't know. Some training caregivers can be difficult sometimes. Maybe they aren't up to what the codes are and you have to tell them. Maybe they haven't come to terms with what their child's illness really entails. Maybe you need to teach them how to flush a G-tube, or maybe you need to teach them some techniques if it gets blocked. Maybe there's something that they just really can't grasp or don't want to grasp, that you know that when they go home they're going to have to face that, or they're going to have to get that medication in that child. So if there's a trick that you know, train the caregivers to be able to do that at home. You're going to enable them to better care for the patient, and that's what the ultimate goal is. Next is finding answers. This one's difficult too, because the truth be known, sometimes we don't have all the answers. But when a family asks you for help or asks you, where are we, or how are we going to go home with this, go find the answer. If it requires talking to a doctor, talking to the charge nurse about, what are our instructions going to be when they're dismissed? What are they going to go home with? Sometimes the answer is going to be, we don't know. And that's hard. But even if you come back with a we don't know, at least you tried to get an answer for the family. And that's really important. Communicating with caring is a difficult one too, because sometimes communication involves no words. So I'm going to give you an example. Back in 2009, Caleb had multiple GI problems, and he contracted an illness called C. diff. It is the most horrendous, terrible smell ever. If you walk in the room, you know what it is. And I was met at the door because I'd pushed the red button and called for a nurse, and my sister and I are trying to get everything under control as much as possible, and he's miserable, of course. And I call for the nurses to come in and help, and I meet a gagging nurse at the door. That's not what you want to see. and she couldn't handle it, and I really didn't want to hear her complaints. So she excused herself from the room eventually, but communicating, all she had to do was walk in and gag, and I knew exactly where she was not cut out for C. diff. She needed to find another area of expertise. So when you open the door, if you're not able to deal with whatever's going on, and we've had this several times where we have had great nurses who have taken care of us for multiple things, and we've seen them multiple times because you're there all the time in the hospital. But these nurses come in and they get to a point where this is something I just can't do. And they would be gone, and I would see another nurse come whisking in, and I'm like, where did they come from? And the whole point was there was something going on that they just couldn't deal with, or maybe it was too emotional for them, or maybe it was just something that was difficult for them. And so they just went and got somebody else who could take care of the situation and help us through it. So sometimes communicating means stepping aside. Sometimes communicating means that if you can't deal with the problem at hand, that you find somebody else that can deal with it, and then you come back and help where you can and where you're comfortable at. That leads us to building heart-led care. And the first part is putting heart into care in the home. The home of the patient is wherever the patient is. Sometimes that's the hospital. Sometimes that's a long-term care clinic for elderly patients. But typically in the pediatric population, home is wherever they're having to be treated. And a lot of times it's lengthy stays in the hospital. When you think of that, when you open the door to a hospital room, if you think about that as opening the door to your home, most of us lock our doors when we go home. We're very careful as to who we open the door to. And if I hear a knock at the door and there's, somebody that looks like they're disgruntled or they're selling something, I don't open the door and let them in. So if you're met at the door, if you open the door to a hospital room and you don't have a look of kindness, you don't have a look of compassion, you don't have a look of, I'm here to help you, then I don't really want to let you in my home, because that's where I am. So learning that wherever the patient is, that's their home, and respecting that space and realizing that for long periods of time, these kiddos are stuck in the confinements of these four walls and in this hospital room, in this hospital bed. So if you can make your interaction with them a positive one, and when you come into the home of their hospital room, if you can realize that that's where you are and treat them and greet them appropriately, it makes a big difference, because children are extremely perceptive. If you go in thinking they're going to be panicked when you're coming in with an IV that you're going to have to put in, they are going to be panicked. They're going to read your anticipation before you even sit down on the side of the bed ready to, stick them with the needle. But if you can go in calmly, if you can think about what you're doing, if you can interact with them a little bit, if you can talk to the parents and say, we have to do this. What is the best way for me to go about it? What can we distract them with? How can I help them through it? Then you're going to get feedback from the family, positive reactions from the child, even if it's an unfortunate thing like a procedure even at bedside. They're going to be more willing to allow you to work with them. Now we're going to talk about the difference in hope and reality. And I'm just going to give you a couple definitions. Hope is a feeling of expectation and desire for a certain thing to happen. We all have hope. Doctors even have hope. Reality is a thing that is actually experienced or seen, especially when this is grim or problematic. And hope always exists, even in the face of reality. Sometimes you are in the worst of circumstances, and the only way to get you through reality, which is the now, which is the terrible thing that you're having to deal with, is that you have hope that you are going to get through it, and something positive is going to be on the other side of this test. This is difficult, especially for people in the medical profession, because sometimes reality is that there's nothing else left that they can do, and all they can do is hope. This is what drives research right here. is that physicians who know that their hands are tied, that there's not good enough intervention, that there are not enough medications to take care of all these sick kids, this is what drives them, and that is that they hope that they can find something to make things better for these kids. Expressing where you are in life is reality, and sometimes allowing the family and the patient to tell you where they think they are gives you a great perception on whether they've accepted the situation and whether they're living in the reality or if they're not there yet. And we'll go into this a little bit more when we talk about grief in a moment. Another part of building heart-led care is caring for the problem at hand. And this is where we're going to talk about fixing versus dealing. And this goes back to the medical community, and everyone wants to fix something. I know my husband wants to fix everything with likely duct tape or a wrench or whatever. Men have fix-it mentalities, you know, whatever's broke, let's fix it. When it comes to chronically ill kids, can't always fix it. So sometimes you're just going to have to learn how to deal. That's the harder part. That's the most difficult part. Dealing becomes a necessity for the family. And helping families deal with what they struggle with day to day becomes what the goal is alleviating those difficult times, helping them navigate the system, and giving them resources to make the day better for families. The next point is reflecting on where we are. We touched about that a little bit with reality. In facing reality and talking to families, sometimes you can see where they think they are. Sometimes you need help from the medical staff. Honesty from the medical staff is difficult because nobody wants to be the bad guy. Nobody wants to say it like it is. Nobody wants to have to say your child is dying. No one wants to have to sit down on the side of the bed and tell you the truth. But I've seen many doctors sit with me and cry with me and tell me where we are. And those are the ones I respected the most, because sometimes the family really knows where they're going. They just have to have the validation of somebody in a white coat telling them, yes, this is where you're going, this is what the path is, and this is what the plan is. So it's really important for healthcare to be honest. When it comes to palliative care, there has to be determination to make each day a blessing, because most days are going to be pretty rough. So we're going to talk about what palliative care really is. And the World Health Organization definition is the active total care of the child's body, mind, and spirit, which also involves giving support to the family. That's really important because it's twofold. Because we're talking about taking care of a patient, we're also talking about taking care of their family, because the two of them are a team. And in healthcare, everybody is on the team. You're either on the team or you're not. Our team was known as Team Caleb. We had the t-shirts, we had the whole 9 yards. Everybody that was on our team, they could be a past speech therapist, they could have been a past preschool teacher, they could be a current dietitian, one of our pediatric specialists, but everybody who was working together to make things better for him, they were on the team. And so having that team spirit where you are uniting the family, you're supporting the family, it's really, really important. And it really affects the care of the patient. On the board here is a quote that is more directed towards the medical community. I'm going to read that one. Palliative care provides a goal so that pediatric medicine does not stop at establishing that a treatment has failed or that a condition is incurable, but must go on to recommend the best way for the child to live with the disease. And that's what we're talking about here, is that day-to-day care that has to happen that's so important. Many times doctors they feel failed when they aren't able to help a child through an illness. But moving past that and saying, okay, I realize that we can't get better, so what are we going to do to make this child's every day better? That's the most important thing. An example of this is, we were at probably October of 2010, and Caleb passed away in January of 11, so that kind of tells you where we were timeline-wise as far as his condition. And I had the chief of neurology at Vanderbilt Children's Hospital to come in our room, and she was on call. It was her turn to be on rounds, and we'd met her on a couple of other occasions. Evidently, she didn't remember us very well. And she came in and she looked at Caleb and examined him, and she looked at his legs. And at this point, after having so many seizures, they're drawn up, and he's not able to walk, and he was rolling around to get to places and completely immobile, really. And she said, "Why haven't we put braces on this kid?" And I wanted to smack her. She hadn't read the chart at all. I'm like, are you kidding me? I'm sure my face, I'm sure the reaction that she got from me, I don't remember saying anything, but I was like, really? And I did tell her, I said, you know, walking is probably the last thing on our list of to-dos. At that point, walking wasn't important. Controlling seizures was important. Being able to feed my child like everybody else feeds their child is important. So walking was on the list, but way down on the bottom. So she went back out and she read the chart. And when she came back in, her demeanor was different. She had read his EEG, and then she knew where he was. And her reaction and her talking to me changed from, "Can't we put braces on this leg?" to, "How can I help you?" So sometimes reading the chart is the most important thing, and realizing that you're no longer treating and curing the kid, that you're making every day, trying to find a blessing in every day to make that child enjoy what they do have of life. So now we're going to move into healing families. One of the biggest challenges is eliminating challenges for caregivers. Sometimes there's limited resources. Sometimes there are difficulties at navigating the system. And as healthcare providers, you have an opportunity to help them correlate all of those necessities into something that works for each family. It involves listening to concerns. If you listen to the family and you know what their greatest concerns are, or their greatest barriers are, or their greatest difficulties, what they have been, then you might be able to steer them into a better place, a better set of resources, so that they can access what they really have the most need of. That can be difficult to do if you don't have centralized care, but if you can find a case coordinator that can help them to develop a system for therapies, a system for accessing home health. There may be supplies that can be coordinated, that can be drop shipped to their home. If there can be a case coordinator that takes care of this family, who makes sure that they're getting all the resources that they need, you're eliminating a lot of challenges that they face on a day-to-day basis. Sometimes it's as simple as getting diapers for the kid, or just finding a good therapist that can come to the home to work with them, because there are insurance problems and time constraints and difficulty in getting them in between medication schedules and feeding schedules. So if you can find out a way and help them navigate the system, you're going to be doing a great deal in healing and helping the family. The next part is developing a plan. And I'm pretty sure that in all of our stays that on Caleb's chart, there was probably a big red note that said, "Mom will not leave without a plan," because I wasn't leaving without a plan. A lot of times when we would go to the ER, the reason that we were there was because the specifications were, if he's had 150 seizures today, and they're concurrent, and you can't get them to stop with extra transine, and you've given him 20 milligrams of rectal diastat Valium, and that doesn't cut it, then you bring him to the ER. So we would. And after 4 or 5 days of staying in the hospital, we're ready to go home because they'd added another medication, or they'd added something else, or increased a dosage, or a dosage was low. And once we got all those things balanced out, now the question is, what brings us here next time? Why do we come back? You can either enable me at home to take care of it, or you can, and it's not an or, and you can also tell me what are the circumstances to which I need to come back to you because we need to intervene here. So making sure that the family leaves with a good plan that's tangible, that's something they can look at, so that in the moment of, 200, 300 seizures, when they're panicking, they know what the plan is and they know how to follow it. You've enabled them to take care of the patient, and that's really important. And if they find that they're going to have to bring to the hospital once again, which is typical of chronically ill children, they know what that plan is. They know that you're expecting them. They know that you're going to know as a physician or as a nurse where they're at when they come to you the next time. The next point is recognizing grief. And this one's difficult because we all grieve. Anytime there's a loss, you grieve. We consistently experienced loss with Caleb. We grieved constantly. He lost his ability to speech at around age 4.5 to 5. So that was difficult. We grieved that. Anytime there's loss, there's grief. Even if the child's still alive, they lose that ability to walk, you're going to grieve that ability of that child. So when you're dealing with chronically ill patients, they are constantly deteriorating. They're constantly regressing. So that family is constantly going through stages of grief. If you can recognize what grief is, when you open the door and they've just been given another diagnosis and the mom is mad, you won't take it personally. Because she's not mad at you. She's grieving. She's grieving another loss that her child is having to face. And that's difficult. It's difficult to recognize. It's difficult for the families to have to go through. Many times they live in denial for long periods of time that they don't want to recognize where their kid is. It's easier to just not even have to face it. But that's where their hope is overriding where they really are. And so if you can recognize grief, if you can help them through that, if you can not take it personally when you know that they're facing another loss for their child, that's going to help you in healing the family, because you can direct them and provide extra support for them. Sometimes it's just a listening ear. Sometimes they may need to be directed to a spiritual guidance. Sometimes they might need to be directed towards maybe a team support, or maybe they don't have a lot of family in an area, so they need resources like another organization that can come in and help them navigate the system and help them direct and provide some additional support, because there are other families out there who are going through similar circumstances. So if you can direct them to these resources, you're healing families. Here are some lessons from Caleb, and I'm going to touch on 2 that are medically related. First is autism. Behavior from a special needs child means not that they're angry or cantankerous or pitching a fit or they're just moody. It means that we as adults are doing something wrong. You can do one of 3 things, or actually 4. You can ignore it and just keep on seeing behavior. Or you can fix it by communicating differently. If they don't understand you, you're going to see behavior every time. What do 2-year-olds do? They say no. They get upset. They have a meltdown. Why? Because they can't communicate yet. They don't have all the words that are needed to get through a day, to tell you, I needed my juice and you didn't understand what I was saying. They don't have all those words. Fix it by communicating differently. If they are a visual child, show them picture cards. It's going to make your life a lot easier. Communicate with the family and ask them what they need. Another option is removing what is uncomfortable about the situation. Sometimes bright lights are difficult for kids with autism. Turn the lights down. It's not that big a deal. Sometimes you're not going to be able to remove what is uncomfortable, like an IV. But if you can cover it with a splint so that they can't see it and get access to it, and cover it with stickers, they might be a little bit more okay with having to have an IV in. Sometimes you can distract them with something that's desirable. So, you know, it's pretty easy. Most kids are, if you will do this for me, then you get this reward. So are kids with autism. So if you have to do a procedure, if you have to have them to be really, really still for a certain amount of time while you're wiring an EEG to their head, if you can do that and give them something desirable for helping you, then you're going to see less behavior. We had a great EEG tech who always wired Caleb in. I couldn't even tell you how many times he'd had an EEG run. And she knew that he liked to have his head massaged right here. So she would sit, I don't know how she did this, she had to have 3 hands, but she would massage his temples and grab a lead and stick it on his head. And then she would massage his temples and sticky another wire and stick it on his head. And so we always asked for her because she was great. And she knew how to distract him. It was uncomfortable to have to lay there to get an EEG stuck on your head, but she knew what he liked, and so she would provide that for him to calm him, to enable her to wire him up yet once again to another EEG. Now on to epilepsy. If you think it's a seizure, it is. Most people don't know what seizures are. They have a misconception of what a seizure is. They think it's a grand mal seizure and that it's the full-on eyes roll back in the head, the arms are extended, they're stiffened, they're shaking all over. You need to learn about seizures because that's not the only kind that exists. There are 2 kinds. There's generalized seizures and there are partial seizures. Generalized are what in the old days they called grand mal seizures. And partial seizures are partial seizures. It involves part of your brain. Generalized involve all of your brain. And so if you can learn more about seizures, there are about 9 different kinds of generalized seizures. So if you can become familiar with those and know what they are and listen to those who have seen the seizure, and when they're describing it to you, think about what seizure type this might be, it's going to be beneficial to you. Also, you need to learn how to respond to a seizure. My husband, we've seen 157,000 seizures in Caleb's life. And that's pretty devastating. But my husband was at Kroger one day, and the gal checking him out went into a full-blown tonic-clonic seizure right there at the checkout, and all he was getting was a gallon of milk. And it really rattled him. And he was like, you know, 157,000 seizures, and I'm sitting here going, what can I do for this gal? You know, how can I help her? And it was known that she had epilepsy, and, you know, the office staff came down and took care of her and got a medic, and they, you know, took care of her. But regardless of how many you've seen, if you know how to respond, if you remain calm, if you get help, that's really important. So a great resource for that is epilepsyfoundation.org. Anything you ever want to learn about seizures is on there. And also if you go to calebsmom.com and you click on About Epilepsy, I've listed every kind of epilepsy there is and what most people see as seizures or have seen as seizures, give you a real life account of what kind of seizure, under what kind of seizure it is, what we actually saw. So I hope that's a really good resource. You have to listen to moms because moms know. And this is just a couple slides about our schedule. And this was our medication list in December of 2010. And we started at 5 in the morning, and he was done around 11 p.m. with medications. And when you're dealing with children with chronic illness, this is a lot. This is a lot for anybody. This is a lot for an adult to have to deal with. I think at this time he was on 4, maybe 5 anticonvulsants. He was on several medications for stomach issues. This is day-to-day life. Here is a daily schedule of what we needed to do to take care of him. And it started at 5 in the morning, and we were done at 12 midnight every day. And this included breathing treatments, connecting feeds, flushing tubes, giving him medications, We were on a rotation of at least 3 breathing treatments a day. Sometimes it was up to 4. This one doesn't reflect the 4 schedule, but when you're dealing with families with children with chronic illness, or any family that has a family member with chronic illness, this is what their day looks like. So they're nurses and they're doctors and they're caregivers 24/7, and there's very little room for sleep, especially when most of these kids who have epilepsy don't sleep very well through the night. So here are a couple other lessons from Caleb. One, love transcends illness. Love will get you through a whole lot of things. And if you have the right heart and you're really going into healthcare because you really want to care for others and take care of others, if you are having heart-led care, then it's going to get you through having to deal with illness every day, because that's what you're going to see. You're going to see illness every day, and sometimes it's going to be very difficult. Patience is a really good virtue to have, especially when you're dealing with chronic patients. Looking for the good is going to keep you happy. You find one good thing that gets you through the day, it will keep you looking for another good thing the next day. When you cannot cure them, the little things in life become much more important. Sometimes just seeing them smile just one time, in maybe even a month, will get you through to the next month. So if you can remember that and look for the little things, and in healthcare provide little things that can be something uplifting for a family, it's going to benefit them in the long run. Also, the last one is being the blessing. And those who are entering the healthcare field, you all have an amazing opportunity to reach out and take the knowledge that you are given in your schooling and turn it into something that can impact the actual life of another person. And that's pretty important, and it's pretty impressive and admirable. Whatever capacity you all may choose to work in, and some of you even as parents will unfortunately have to go down these roads. Along the way, you're going to meet some precious kids like our Caleb. And in doing so, you have the opportunity to be the blessing in their life. And I think that you all will find that along the way that these kids, these chronically ill kids, will be a blessing in your life as well. Well, thank you all for having me today. It's been a pleasure, and I wish you the best in your journey, wherever it takes you. Thank you.